the Dementia Researcher podcast, talking careers and research, sharing conference highlights, and so much more.
Hello and welcome to the Dementia Researcher podcast. I'm Adam Smith and this is the second of our daily highlight shows from the Alzheimer's Association International Conference, or AAIC 2026, taking place in London and online. There's a tremendous amount happening across the conference with presentations, posters, panels and conversations all taking place at the same time, and none of us have time to see everything. So throughout the week, we'll be bringing researchers together who have been attending online to compare notes and share some of the work that's caught their attention. Joining me today to look back at the second day are Nathanya from Universitas Airlangga in Indonesia, Dr Arezoo Talebzadeh from the Ghent University in Belgium, and Dr Suelyn Koerich from the University of Texas Health Science Center in Houston. Hi, Nathanya, Arezoo, and Suelyn. Thank you so much for joining the podcast.
Thanks for inviting us. Hi.
So before we get into today's conference highlights, let's find out a little bit more about each of you. So I'm going to ask you to each introduce yourselves and tell us a bit about where you work or study and give us a quick overview of your research interests. And Nathanya, I'm going to come to you first.
Okay, so hi Adam and hi everybody. My name is Nathania and currently I'm a medical student on my third year and based from Indonesia. And I work a lot in neurology research because that has been my main interest, especially with Alzheimer's disease and other neurodegenerative conditions and also infectious disease. So I'm actually an early career researcher and I hope to move forward, as well as joining AAIC is one of my goals to improve further.
That's exciting. So what does a day look like for a third year medical student? Are you in the classroom or are you out in the hospital?
So we had our classes in the hospital right now, but we're not in the clerkship yet. We're just like studying in the hospital.
Wonderful. And is this your first AAIC?
Yeah, I had my previous iStart conference, but it was the AAIC Neuroscience next. It was February this year.
Wonderful. Well, thank you so much again for joining us. And I'm going to come to Arezoo.
Hi, thank you again for inviting me. My name is Arezoo Talebzadeh. As you mentioned, I am an architect, but I did a PhD with Ghent University in Belgium on Soundscape and Dementia. The idea was that we can augment the auditory environment, and through that, we can lower BPSD in the people with dementia. So I did this study in Ghent University, but I did my data collection in Toronto rehabilitation in Canada. So that's why I have both sides of the pound experience working with people who have dementia.
That's wonderful. This might be surprising as well, but you are not the first architect we've had on the podcast.
Ooh, that's good.
We had somebody called Andrew Lashley join us, who's Tamrin Lashley's husband, but it wasn't about dementia. It was about, we had a show where we talked to the partners of dementia researchers to say what it's like to live with a dementia researcher, and he was an architect too. But it's been an interesting topic. I know I've seen lots of work come out of the University of Stirling looking at care environments and how you build better environments that can facilitate and lend themselves to care in that out-of-home setting.
Yeah, exactly. In my everyday job, I design long-term care. So I try to bring this research and real-life implementation together, hopefully.
Is it the Netherlands as well that have put a lot of thought into care home settings and community spaces?
Yes, Netherlands is very famous for.
Well, thank you very much again for joining us. And finally, Suelyn, thank you so much for waiting.
Hello, everyone. Nice to meet you all. So I'm joined from Houston, Texas. I am Suelyn Koerich. I am a postdoctoral research fellow at UT Health, Houston. And my research focus right now in Alzheimer's disease is mainly in neuroinflammation, microglia, and therapeutic approaches. So I'm really excited to be here and share of the highlights of the day with you all.
That's great. So we've got some really broad perspectives. I don't think any of the three of you will have been to the same talk. So we've got the clinical side, we've got the care and architecture, and then we've got the fundamental science covered as well. And me that knows nothing about any of them trying to float over the top of you. That's wonderful. Thank you so much, all of you, for joining. So let's now turn to the conference program, where on day 2, as I mentioned at the start there, and what was the first thing that you saw or heard today that really caught your attention? And I'm going to come back to you, Arezoo.
So I'm just going to mention that because I'm in Toronto, I'm a little behind time-wise, so I missed all of the early morning sessions, and I started in the afternoon sessions. I have to go back and watch them. But in this, and because I have an architecture background and not a physician, so my interest is maybe a little different. There was a session this afternoon about designing for inclusion and how to engage communities that usually not be involved in the data collection to come and have a data collection, which is very interesting because I always want to do that in my own research. And there was a couple of speakers that I find very interesting. Dr. Luis Medina from University of Houston, and they look at how the presentation of Black communities and Hispanic communities is usually lacking in the data collection. And they had this idea of how we can bring communities to get involved. So they have this initiative under the Alzheimer Society called Brain Trust. So they try to go into the community, make that connection with them, make the trust, because the data that they have show that till now, most of the research, only 1.2% of the participants are Black communities and about 5.6% from Hispanic. So they're trying to change that narrative, because as we all know that if you don't have everyone in that research, then there's just very biased, the data. So one thing that I find it very interesting about their work is that they're co-designing with the community how to can make them to trust the researchers and how to can bring them into this idea of the participant in the research. And they also, for Hispanic, for example, they use the Spanish language people to go and make that trust. So I find it very interesting, and I really like to follow up with them and to see how they grow their research, bringing more people and making more inclusive.
What were there some kind of lessons that they've learned? Were there any kind of top tips from that study that would?
The most things that they learned, that the way they have to make the trust. It's not that people don't want to participate, but because people, maybe Black people, because of the history of they have, or Spanish people, because they cannot make the communication, they don't trust. And they find that the best way to make that trust, to go with the community, make sure that they co-design the research with them and not for them, as we always say in inclusive design. So they find that one of the tips that they said that it can work for everyone else. So they do that. And I find it very interesting because usually when we talk about the researcher would say, well, I don't know how to find people with diverse background. So one way is that you have to go to the community and start the conversation. So that's what one of the highlights of the research.
Yeah, that's a kind of very clear message, isn't it? That's been coming out from all the public and patient involvement work and co-design work for a long time now. You've got me thinking, actually, though, that something I haven't seen talked about much before, and I thought this is where you were going to go with this, is about the environment in which the research takes place. So, given that you've got that white coat syndrome, that people either, respect and don't listen to everything you say, or they are scared of going into a healthcare setting, or have that fear and that stigma that can be associated with that, whether there's some research that could be done to look at the environment, particularly also as well, if you're going into a medical setting where it increases your anxiety, your stress levels, that the results you might get from the tests you apply in that environment will be very different to if you applied them in people's own homes, or if you created a setting where people felt more comfortable to do that.
That's a very good point, actually, because not for this specific talk, but for Soundscape research that we do, we sometimes say that we want people who are like marginalized population. We want to design for them, but how we have to go to their spaces to understand their soundscape. Or if people have dementia, we have to go to their spaces. If you sit in the lab and ask everyone to come, as you said, they may never come.
No. And not everybody's, I mean, obviously, not every kind of test you can do could be delivered in somebody's own home. Sometimes people, like it or not, are going to have to visit some kind of healthcare setting or someplace. But thinking about how, I mean, we do this really well for children, don't we? If you think about it, if you're going to a children's hospital, there's going to be murals on the wall. There are going to be toys there. It's going to feel soft and warm and comfortable environments. I wonder if less has been done to consider how you might make an environment feel welcoming for older people. If you are aware of research into this and you're listening, do drop us a line and let us know in the comments, because I'd love to read more on that, because I just feel like it's perhaps an underexplored area. Something to look at, Arezoo.
Yes, exactly. Where are the architects who designed these buildings?
Thank you very much for sharing your first highlight. And now I'm going to come to you, Suelyn.
Yeah, so one presentation that was interesting to me was by Dr. Hene Hostage. I don't know if it is the right way to pronounce it. She's from Amsterdam, and she presented the findings from 100+ studies. So it's a longitudinal cohort related to cognitively healthy centenarians, with some participants that donating their brains for neuropathological analysis after death. So what I found especially interesting was that many of these individuals had amyloid pathology, but still maintained like a normal cognition because they accumulated very little tau pathology. So I thought that was fascinating stage of the amyloid hypothesis, because right now the concept of cognitive resilience railing in simple disease resistance. And I found this particularly inspiring because as we understand these protective mechanisms, we could eventually help us develop therapies to promote resilience, not just reduce the pathology. We cannot just focus in the amyloid pathology as well.
Absolutely. Did she have any theories on what might be those protective resilient factors, or was this just, was it good genes?
Yeah, they mention a good environment, share a good time with people that they must love, the health foods, exercise, all these things that we know is good for maintaining our brain resilience.
I've seen her present a few times now. I think from
Yeah.
AAIC last year and ADPD
Yeah,
the
me
year
too.
before. And she gives a great talk. I love that slide that she often puts on at the start, showing you pictures of older people. If Arezoo and Nathanya, if you haven't watched this talk yet and it's online, go watch it because it's always great.
Yeah.
She puts this slide up with lots of pictures of older people, and then asks you to guess how old they are. And usually you would guess that they're probably in their 80s, and they're not. They're all centenarians. They're all over 100 years old. And what I've always found fascinating is that these aren't people who've lived healthy lifestyles their entire lives. That they've smoked and they drank and they've had children and they've had stressful periods. And it's really interesting. That shows that resilience is a complex thing. It's not just made up of, it's not just to say, well, we know, don't we? Because some people who smoke don't all go on to develop dementia.
Yeah, it's
And
good because this message gives us like that not only the amyloid or tau pathology alone determine cognitive decline. It's umbrella factors.
It's super. What do you know? Was there something particularly new? Because every time I see her, she's added something new on to. I often see the same data again, but then with something new. Was there a new addition to today's talk?
Yeah, she mentioned something about more preventing that, preventing or delaying the transition from amyloid to tau pathology. Something like that. That is more new. I think.
Yeah.
I lost the word. So it's more preventive that like a late disease.
That's great. And I know that they've got a great website as well with a lot when they're constantly kind of sharing their data from that Centenarians study. So that's wonderful. Thank you so much, Suelyn, for your first highlight. And Nathania, I'll come to you now.
Yeah, so I think there's so many interesting sessions of AAIC this year, and as always, but I think that the plenary sessions really get me amazed because it's one of my interests, which is the anti-amyloid immunotherapies. It's been very emerging this year, and we always understand that this is genuinely a new era for the Alzheimer's disease because we finally have drugs like lecanemab and donanemab that can slow the Alzheimer's disease by clearing the amyloid plaques. Although there has been a lot of reviews and also responses that are pros and cons about this therapy, we should acknowledge again that this is a very emerging era of Alzheimer's disease. And I saw that Dr. Schindler, that she mentioned a lot of amazing, important things that I can get, especially as a medical student, is that we can see about the patient's symptoms and also the patients that are going to get the therapy. And the patient that walks into a real memory clinic is not something that you can stereotype. And as her own experience that she saw a lot of patients in the clinic every year using various subsets of tests and to screen about their eligibility, there are actually so much things that we need to take care of because that not everybody that are cognitive impaired are actually eligible for the treatment. And this is the thing that we should take in notice.
Yeah, I've just come off the back of watching that same talk too, and I really enjoyed it. I thought Suzanne Schindler did this great way of bringing storytelling. Anybody who gives you a real life example, like this patient comes in and this is what happened, it really helps me understand what she was talking about. She was focused on those real world challenges of figuring out who should and shouldn't get these new anti-amyloid drugs. And to cut what was a really long talk, you've already summarized this really well, but the main message was very clearly that treatments exist, but there's this new diagnosis bottleneck, and that clinical assessments alone really miss a lot. And so we really need those biomarkers, but those biomarkers need to sit in that, they need to be scalable, and they need to sit in that primary care setting, focused on that p-tau 217 as the most current reliable blood biomarker. But yeah, that take-home message that this has got to sit in primary care, and I loved her storytelling.
Yeah, it was really brilliant and bring us a lot of perspectives, and that actually leads us into something that we can call as personalized medicine, where we can actually understand every single patient to give them the best care, especially for Alzheimer's disease.
Absolutely. Thank you very much. So that gives us our first set of highlights, but there will have been plenty more happening across the conference. So let's move to something different now. What did you see or hear today that you think is worth sharing with our listeners for your next highlight, Arezoo?
So something that I want to mention, actually, I think it was yesterday's session, but I watched it today. So it's on climate change, war, and migration. I want to talk about this because I find it very interesting. Dr. Marco Canavelli from University of Rome, and he had a very nice presentation. So if anyone interested, he explained it very well, much better than I wanted to say now. But they look at migration and refugees population in Europe and the lack of cultural assessment for dementia. And I find it interesting because, for example, mini mental assessment is what I even use in my research. And it's on English, and then you talk with people. Maybe there is a translator in between. But sometimes when you translate these assessment in the culture, it doesn't really work that way. So we always have to find out the best way to actually can assess, do these assessments. And then the cross-cultural cognitive assessment is very important. And it's also in the Soundscape studies that I do, even if the people don't have dementia, the set of the assessment that we do is basically based on Western culture and knowledge and not around the world. And then just imagine that if people are refugees or they're immigrants, and now the number of people with dementia in that group is going up because they're aging. And the talk said that in 2019, 500,000 people in Europe, they have dementia between the immigrants only. And then you have to find the best way to go and assess them and how to can actually communicate with them. And there is a lack of study in those specific group. I find it very interesting, especially if I want to use the Soundscape for the people who have dementia in the long-term care home. For example, in Toronto, I know that the population that I have to design with or design for them, they're coming from all around the world. And how I can use this method that they are going to use to have the best result for my participants, or if I'm designing for them. So I find it very interesting.
Have they, did they have some recommendations? Have they been designing some specific kind of culturally sensitive?
They are looking at countries that they already have some dementia strategy, and they said that there's just a very few. I think in Europe, Austria, Belgium, Netherlands, and maybe Sweden. Canada has one, I know. It's just in the progress of making it wild and accessible for everyone, but they are still looking at to making one that can work more for more people.
It's interesting, isn't it? Because I think quite often we find that people will jump to creating their own thing. You know, I've seen this in the UK, where they want to have culturally sensitive assessments for, say, South Asian populations of people living in the UK. Whereas, of course, you'd imagine that the first thing we would do would be to go to South Asia and say, what assessments do you use? We'll adopt those. And I think often in countries where we live, we jump to making our own rather than just looking to what already exists in the places where they are and adopting an existing. Now, I appreciate that doesn't always work, because some of those places in the world might not even have their own assessments. But you'd imagine that that'd be the first thing you would try to do. More broadly, I do think, I do worry. We talked a lot about people living with dementia and the impact of conflict and migration on them immediately after the conflict in the war in Ukraine broke out. And there was a lot of concern saying, hey, people can't get medication. They're trapped in these places. What do we do about that? But that war is still ongoing. And I don't remember hearing anything about that, 6 months later. And I'd certainly like to see more of that. If there's some AAIC presentations talking about people with dementia in conflict zones or difficult parts of the world, I'd love to hear more about what's being done to support that, because it seems to have gone quiet.
Yeah, effect of trauma, actually. Do we have like war trauma and any relation with dementia or early dementia? That would be interesting. Not interesting, but something that we need to do.
Well, access to carers, to safe environments, to medication, to whether this speeds progression, which you'd imagine it can do, or does the whole issue of the conflict just become the most important thing that people with living with dementia become so unimportant in the grand scheme of things, which you'd hope isn't the case. But you worry that might be what happens. Thank you very much, Arezoo. That was a great second highlight. Nathanya, I'll come back to you for your second update.
Yeah, I think I like to continue with the story of Dr. Schindler. And we had Dr. Acosta. She is also in the plenary session. I'm choosing this both because they're both, I feel like, can be correlated in some part of way. And she is the investigator of the 10/66 Dementia Research Group in the Latin America. And in here, we get to know about the perspective that comes from Latin America. And that is very important. And it will be great if we can have perspective for every regions. And from her presentation and her talk, we can see how the prevalence and how the development has been going since the mid-2000s to 2016 to 2019. And numbers are moving so fast. For every region, it differs. For example, like Dominican Republic, and then for Peru, and also Mexico and Cuba, there has been a lot of divergence in the story, and where it tracks into multifactorial analysis again. And we can see also about like education, cardiovascular risk management, and this, in a way, we can see granularity country per country, not just like generalizing as in one regional trend. And I felt this one really personally because I think perspective from countries like where I live in Indonesia are not often discussed as well. So it might be great to work on this kind of thing in the future.
I watched that talk too, and I thought it was really interesting how she'd flagged that there were stable rates in Cuba and Dominican Republic, as you mentioned, but women were still more consistently affected, and that the differences that they were seeing though do seem to be driven by social and modifiable risk factors and not genetics alone. So I thought it was an interesting talk, and again, it was one of those big plenaries of the day, wasn't it? What could you see some similarities in that work? Is that the kind of work you'd like to see happening in Indonesia?
Yeah, of course. I think that maybe sometimes some countries might be recorded as not really in the urgency, or they don't have any high prevalence of Alzheimer's or dementia, but it could just be as underrepresented. For example, like the national surveillances that did not work really closely to survey the whole country. So I think that should be more emphasized to every of the countries and also everyone that's involved. So I think that it don't just like involve in one sector, but everybody to work together to make this come true.
Thank you, Nathania. And Suelyn, very patiently waiting. Give us your second highlight.
Yeah, so regarding what Nathania said, one talk that caught my attention was from a Brazilian research group. It was Dr. Paradella, and she talked about the neighborhood deprivation and cognitive decline in Brazil. So as someone from Brazil, I was happy to see research using Brazilian data because we still need more studies from countries like Brazil. The researchers looked at whether the neighborhood or where people live affects their cognitive declines. And they found that people living in poor neighborhoods had a faster decline in the executive function, even after considering age, education, income. So they did not find the same result for memory. And I think this study was very important because it reminded us that dementia is not only about biology. Where people live and the conditions are around them also is very important. This is especially important for countries like Brazil.
Absolutely. It's really weird you pick on that because I've highlighted 3 posters that I wanted to talk to. And I don't know if this is the same research. So this was by Nubia Alcentar Freitas, and it's called Education, Social Isolation, Homebound Status of Dimensions of Cognitive Vulnerability in Brazilian Primary Care. It's a mouthful. But I don't think it's the same study. This study looked at 139 older adults who were receiving community-based primary care in Brazil and asked how education, social isolation, and how being homebound related to their cognitive impairment. And the team classified participants through this multidisciplinary assessment and then analyzed whether each factor remained important, accounting for age and gender. And they found 2 kind of striking opposing effects: that every additional year of education was linked to a 13% reduction in the odds of cognitive impairment, while social isolation in older adults had more than 9 times as many odds of impairment. So the more educated you become and less socially isolated was a massive difference to those that were in those other ways. And being homebound showed a possible increased risk, but not statistically that important. And I really like that poster because it gave this kind of clear public health message that cognitive health is shaped across life course, that education, even if earlier in life, and that loneliness and social disconnection in later life are important too. So it's really interesting. We both picked up on that research in Brazil, and you see so much of this research looking at dementia prevention and things coming from Brazil. Were there other studies and research you've picked up on coming out of Brazil in this same space?
Yeah, I think if first this study you mentioned is a second study. They have 2 big studies in Brazil. Because Brazil is very broad. So we have many social and economic difference. So they have these two studies trying to understand how these differences affect brain health and can support a better public health policies. So I think in Brazil, we have a lot of problems related to economy and also related to research. We have a lot of researches going on, but we don't have a lot of resources to publish these studies or to look around the country as well. This is one of the main problems. We have a lot of things happens, but we cannot access this data or sharing this data. I think this is one big problem because we don't have enough resources.
Although I have to say, I think Alzheimer's Association have been a great champion for putting funding into across Latin American research, which has made such a huge difference because so many of the big talks that I've seen already over the first 2 days and that are coming up is of research coming out of Latin America, which is amazing, really great to see. It's not amazing. It's not surprising. Just why wouldn't it? But it's brilliant to see that that part of the world is getting the attention and delivering on some fantastic work.
Yeah.
Thank you, Suelyn. So we've had 2 highlights from everybody. I'm going to come round the table one more time and we're going to ask if there's maybe a little bit of a smaller talk you've picked up on or one of the posters you've seen. And I'm going to come back to you, Suelyn, to start this time around.
Yeah, I saw a small talk from Dr. Alexandra Gogola from the University of Pittsburgh, and she talked about the complex interplay between astrogliosis and Alzheimer's in non-dementia individuals. So I think that was very new and exciting to me because we are only mostly of 100% of the time focusing AD individuals. So she explored the complex between astrogliosis, amyloid, and tau pathology in people, health people and people living with mild cognitive impairment. So what I found most interesting was that the data suggests that astrocytes may play both roles during Alzheimer's disease progression. Early reactive astrogliosis appear to reduce the relationship between amyloid accumulation and downstream the tau pathology. And however, as the disease progressed, astrogliosis also became associated with neurodegeneration and cognitive impairment. So as someone working with neuroinflammation, I thought that was very provoking study because it reminded me that glial response are not like simple. It's harmful or it is beneficial. That may change during the disease progression. And I think we should talk more about that in your research. It's not only focus in one way. I thought that talk was very interesting.
Wonderful. How did you come across that talk? Was that one that you went out of your way to deliberately look for, or how did you come across that one in the platform?
I searched for glia.
So that's just top tip for anybody who's watching. That there are loads of different ways. You can search by author, you can look by topic type. You can also just do some keyword search and say, hey, show me some research on music or on microglia or on tau or whatever it is. Thank you very much, Suelyn. Nathanya, I'll come back to you.
Yeah, so I would love to talk about the featured research sessions. So there are 2 sessions that really catch my eye. It's about the social determinants of health and Alzheimer's disease-related dementia. And also the other one is to evaluate the national, such as social determinants of health in low and middle income countries. I think that this gives us a lot of new perspective. It's about to maximize, not just about preventing dementia or looking at a better prognosis, but also to build like a community that understands together, and that comes into maximizing the biological, cognitive, and psychosocial outcomes that I actually understand from the sessions. It actually sounds really broad, but it also brings us back that Alzheimer's is not about just getting the tau pathology or like the amyloid pathology, but there are a lot of different trajectories and also multifactorial, like what I mentioned before, like education, income, occupation, health literacy, the pollutions, like climate changes, also food insecurity, and many more. It's really limitless when we talk about other factors that can influence about the disease. But that actually inspires me that this should be a movement that we all be aware of. It's like to evaluate the national brain health programs across countries. And we hope that every country has this dedicated programs, because I don't think that it is actually applied equally in the whole parts of the whole world. And also we need to assess the implementation and also to compare or maybe to discuss about the prevention strategies across countries, where there could be like a dedicated plenary session maybe in the future, and also to study how the healthcare infrastructure can actually affect all of this. And I think that kind of like factors that seem so broad can actually transform about the care in Alzheimer's disease and overall.
Yeah, I think we often talk, don't we, about personalized medicine, but the same ought to apply for policies when it comes to looking. Not every country necessarily needs to put addressing dietary concerns at the top of the list, or climate. No, we all have to put climate change at the top of the list. That's just a fact. But was there any kind of social determinants there that you felt came out as being more urgent than others?
I think the most important thing might be education, and also about like maybe people that has exposure to like social isolation or maybe other psychological factors. I think those both might be overlooked, at least in my country, but that should be worth to be looking out for.
Thank you, Nathanya. Arezoo, we'll come to you for your next.
So you talk about how this conference makes it very easy for us to search words. So of course, when I go to acoustic conferences, I always search for dementia to see if anyone else is interested. When I come to this, I search Soundscape, and I find one poster actually that they did a Soundscape evaluation. So the poster name is Processing of Real-World Soundscape in Alzheimer's Disease and Primary Progressive Aphasia. And the number is 6437, if anyone wants to go and see it. It's from UCL, and I find it very interesting because they look at effect of soundscape on people who have dementia and primary progressive aphasia. And when we talk about the soundscape, is every sound that you hear in any environment and the effect of sound on each person. So for example, everyone has a different reaction to the sound of the cities, the car traffic, birds singing. So they look at this and they realize that, so even the people who have the hearing impairment, they don't have a hearing impairment, because of the type of the disease that they have, their understanding of the soundscape goes down when they have Alzheimer, especially when they have a logopenic variant of PPA. And this is very interesting because this is very close to research that I've done with people with dementia, because at the end of my research, I went through different type of dementia and look at how each type of the disease changed the auditory scene analysis in people who have dementia, which means the way that we understand the environment through listening and hearing. And this one actually was, they went one step forward and actually did the test with the people who have this type of dementia. And the understanding is that for these people, the understanding of the scene through hearing there's a deficit there, because there is an interference between perception and semantic memory and episodic memories. And then, so someone like me who wants to design a soundscape to augment the soundscape for people who have dementia, I have to look at the specific type of dementia to make sure that what I'm adding to the scenery is just actually work for the person with that specific dementia that it's very related to my research. So I got very interested to going through the whole poster and reading through it.
And UCL, of course, is where I work too. And Anna Volkmer writes lots of blogs for us, who works in that primary progressive aphasia space. It's a hot area of research for UCL. But I haven't seen their work on soundscapes. That sounds fascinating.
UCL has the largest soundscape study research team. You should go and meet them.
I absolutely will. And well, after we did a relay podcast last week on sensory health as well, and looking at olfactory systems and things, I've certainly, this is my new thing. I think we should definitely be doing more to help people improve their senses if they're going to be living longer with dementia, rather than just using those as biomarkers or sound, indicators of cognition, that actually trying to help people improve their sense of smell or with their hearing, or connecting hearing to help people live for longer in their own environments. Sounds like.
Yeah, not all of us are physicians and we cannot cure, but we can do some other stuff. I, as a designer, for example, I can make sure that the space that I design works well and help with the well-being of the person who have dementia.
Is there a lot of work going into that space? Because I'm a bit of an audiophile myself, and I do always kind of make sure I'm on top of what are the best new noise-cancelling headphones and understanding how they work. Has that kind of technology from noise-cancelling space been used in people with cognitive impairment to help them focus? Because we know that quite often people, even with Alzheimer's specifically, can start to become disconnected if they're in busy environments, so they'll zone out and sit back. But using technology to help people to focus in on single conversations or pick out certain words, is that do you know of anything in that space?
You can use it in reducing reverberation in the room, for example, the same technique that you use in schools when we do it for younger children. So make sure that they can understand when the teacher speaks. The same can be done for the dementia care, but there's lots of research on it. There's not that much implementation yet, but we always make sure that the room is quiet at least. But usually, because these are healthcare settings, there are lots of other sounds that are happening. So in my research, we always said that we have to first evaluate what is happening there. If we want to augment soundscape, we don't want to add to the chaos. Just make sure that that's not happening.
That's a great tip. I will go away and look at that poster. Thank you, Arezoo. So we've heard about some of the work you've been watching, but of course I want to ask about your own involvement in the conference as well. And Arezoo, I'm going to pick on you first because I know you've been presenting. And when you said you looked up sound and you mentioned Soundscape, I was immediately about to say to you, is that your own poster? But it's not. But you've been presenting this week. Tell us about your presentation.
So yes, I have a poster which has the word soundscape in it, if you search the word. So the title of the poster is Mapping Auditory Processing Heterogeneity in Dementia to Target Soundscape Intervention. So as I said, as part of my PhD, I look at auditory symptoms in different types of dementia and the auditory deficit. And then we brought them all together and then make sure that the sound characteristic that we want to put into our soundscape augmentation works with each different deficit. So if you look at the poster, I have the framework that I designed, and it can follow up from the type of the dementia, the type of the deficit, and comes all the way down to see what type of the soundscape can help in semantic masking, energetic masking, or in spatial or temporal orientation, because that's the whole goal of soundscape augmentation that can help people to understand the time of the day that they are in and the space, and they can navigate the space easily through the soundscape as a help. So you can look at this poster and figure out which sound works best for which type of the dementia.
That's fascinating. So can you then say artificially create those soundscapes to encourage certain behaviors, like making bedtime noises at bedtime or clanking plates at meal times or things like that?
So, yep, that's what the research that we did. We did the RCT in Toronto when we have the set of the sound that we played for the people who participated. For example, we started early morning with bird sounds to activate. And then throughout the day, when it's the time to go for have a meal or a coffee, we started to playing the sound of the kitchen or people eating, people talking in the restaurants outside. And then when it got to the night, the sounds that is more nature during the night, birds, but the night time calling, bird calling. And we saw that when we evaluated, we saw that in the morning, the bird sounds actually reduce resistance to care for the participants.
Wow.
So we wanted to lower the BPSD in the people with dementia, but the most one with anxiety came down. But in this setting that we had, the anxiety was supposed to come down anyways. So it was a more relationship, but resistance to care was very went down because, the Soundscape played for them in the morning. And I think one of the things that we want to really work on it is how we can reduce apathy with people with dementia, because apathy is very common with everyone with dementia, and through the Soundscape. So how we can make them to have a more social connection with others or just activate their feelings. So that's another thing that we want to do.
That's really creative, and you can see how you could do that even through music and things like that. That if you want, yeah,
definitely. We didn't have music part of it, but music is, of course, it's music therapy, and music is one thing.
Well, consider this an open invitation to come back and talk about that more on the podcast, because that's fascinating. I'm sure our audience would love to know more about that work.
I should also mention that I am a big fan of your podcast, and I listen to your podcast.
You're very kind. Thank you so much. So we've got, just give us one last reminder. What was the poster called again, so we can get a plug in for that?
It's Mapping Auditory Processing in Dementia to Target Soundscape Intervention. And the number is 2135.
Thank you very much. So we've managed to go through the whole podcast and haven't really talked a massive amount about biomarkers. So I am going to pick up on one poster that I'm going to mention, which was, let me pull my notes over here. So it's called Analytical Validation of Minimally Invasive Capillary Blood Microsampling using TASO Plus for Multiplex Neurological Biomarkers. That's another mouthful. So this was by Owen Swan, and I picked out on this one as well because one of my colleagues, Amanda Hesselgrave, who I worked with on AAIC Neuroscience Dex, is one of the senior authors on this paper. And this poster tested whether minimal invasive upper arm device called a TASO Plus could be used to collect blood samples suitable for neurological biomarker testing outside traditional clinics. So this has come back in again. If you think about blood-based biomarkers coming a big thing now, there's been a lot of talk about how you collect the samples for that and whether this is something that could be done in their own home. And this team compared capillary samples with normal blood samples collected in a clinic with us building in a 72-hour delay from collecting the sample to getting it into clinic. And they found some strong agreement for brain injury markers in GFAP and NFL in both plasma and serum, although performance across wider multiplex protein panel varied depending on the individual biomarker. And that means that this approach is really promising, but it still needs, further validation separately. And I like this because I've seen a lot of a few presentations in the last year about dried blood spot sampling and different ways to collect blood at home. But this idea of collecting this through a capillary device that then people could send in, I think opens up this accessibility. And I'd really like to see this move more into that preventative space, or if we offer more blood testing to middle age to assess buildup of amyloid over time, if we can start to look at that as a predictor, I think that's got potential, and this is going to be one of those key steps in getting there. So well done to Owen Swan and Amanda Hesselgrave on that work, and a bunch of other co-authors. It's a very long list. But that's all we've got time for today. Before we finish, though, I'm going to come to each of you and say, if there's one last, we can't talk about the research, we haven't got time, but if there's one last talk you want to give a little plug to, you can tell us the name of the author and the title of the talk. I'll give you that chance. Suelyn, was there one last plug you want to make for something?
Yes, one study that I like too much was the US pointer. How much is enough? Is by Dr. Rachel Whitmer, University of California.
Absolutely. We haven't talked at all about the pointer study today, and that was that's been their big press release. But if you look on the Dementia Researcher website, we put that press release there with all their information. This is a new news from the the Latin arm of the pointer study? The fingers. Was it the fingers trial? I can't remember. The two were connected. I'll look that up while I'm asking Arezoo to answer that same question.
I find it very interesting that there are so many sessions on aging and women health. I am very interested in the relationship between women health, menopause, premenopause, and dementia. So if anyone interested, there are lots of talk about that this year. I want to invite them to go and watch them all. They are very interesting. As a woman, it's very interesting for me. Has nothing to do with my research. It's just with my own health.
Absolutely. Sex and gender has been so much talked about. We did a relay podcast on that just last week as well. And had a chat, some really interesting chats in our B-Sides, which is our subscriber program on YouTube and in Apple Podcasts, if you want to hear more about that. And I've just checked my facts, and it was the LATAM fingers trial, which is kind of the sister, I think, isn't it, or the brother of the US pointer trial as well, which talked about that lifestyle program did boost brain health across Latin America. And that press release is on our website. And Nathanya, any last plug for a talk you want to give?
Yeah, so you basically mentioned, and Suelyn already mentioned as well, it's about the US pointer and the LATAM fingers. It's really amazing. I hope to see a very good news from them later.
Well, thank you very much to all of you. I'm sure we could easily sit here and talk for another 3 hours because there's just been so much to cover. Although we might have to let all of you go away and watch the morning sessions, which, of course, you've now got the pleasure of doing after we've finished recording today. But Nathanya, Arezoo, and Suelyn, thank you so much for joining us to share your highlights from the second day of AAIC 2026. We'll be back tomorrow with another group of researchers, more conference conversations, and more studies, posters, and presentations that have been attracting our attention. You can find profiles on all of our guests, along with other AAIC coverage on the Dementia Researcher website. And don't forget, there is still time to register as well for the AAIC for All conference, which has a lay track and a clinical track, which is on Thursday and is entirely free and online. And of course, you can find lots of updates on the conference on pretty much every social media platform looking for hashtag AAIC26. But for now, I'm Adam Smith, and you've been listening to the Dementia Researcher podcast. Thank you very much, everybody.
Thank
Thank you. Bye.
Thank you. Bye-bye.
The Dementia Researcher podcast was brought to you by University College London with generous funding from the National Institute for Health and Care Research, Alzheimer's Research UK, Alzheimer's Society, Alzheimer's Association, and Race Against Dementia. dementiaresearcher.nihr.ac.uk